Dr. Kiran will be speaking on combined topo-guided PRK with CXL in keratoconus. How many of you are doing smile from the audience? Okay.
Good morning, everyone. I'll be discussing on topoguided photorefractive keratectomy with collagen cross-linking in cases of progressive keratoconus. As we all know, KC is a progressive bilateral asymmetric ectatic disease with irregular astigmatism and visual deterioration. But the thing, is it clear now? And as we all know, collagen cross-linking is the only procedure as of now we have been practicing in our clinical practice to stop the progression of keratoconus. Keratoconus is characterized by steepening, and there's a lot of irregular astigmatism. And to tackle this progression of the keratoconus, so we have only one procedure, that is CXL. If we do CXL, it just stabilizes or flattens the cornea, and the results are usually totally unpredictable. Some cases responds very well by causing flattening of about 2 to 4 diopters, but some cases really fail to respond. And because of that, corneal irregularity still persists, and definitely there will be poor BCVA, and some cases may even have scarring. So they usually get up to 6.9 to 6.6 with rose scale lenses. So what is a CXL plus? When CXL combined with refractive procedures, as you all know, CXL only gives anatomical stability for the cornea, but the functional results are usually poor. That usually takes almost 3 to 6 months for them to advise for any other vision correction procedures. So there is something called topoguided PRK or PTK, and even with Intax we can manage this. What does it do? Topoguided PRK, it actually flattens the cone of the peak, so thereby it flattening and it broadens the cone. So the total biomechanical strain will be redistributed on the cornea. So definitely at the end of 3 months they'll have a better uncorrected visual acuity, and definitely the best corrected visual acuity. Our preferred practice criteria is we usually consider this procedure for the progressive keratoconus. We have to repeat pentacam at least in a 3 months interval, and if there is any progression noted, we can plan for this procedure. Expected corneal thickness at the apex of the cone after PRK with epithelium, it should be at least 350 microns, and there should be clear central cornea, and ideally it works better for central cones. And maximum ablation, till now Canalopolis has done the cases till up to 50 microns, but in our series we have corrected up to 80 to 100 microns. But our basic thing is we should have at least 350 microns at the end of the procedure, and optical zone can be considered from 5.5 to 6.5, because if we keep more optical zone, more tissue will be ablated. So ideally the 6 is my optical zone which I usually consider. And target refraction, it's never undercorrect, never hyperopia, because that will be very bad for the patient. This is basically based on a refractive coordinated system which is provided by the Zeiss, which has MEL 90, and it and Atlas topographer with CRS master, and planning will be done accordingly. What do we do actually? This is not based on our pentacam values. This is a Placido disc based device, is Atlas topographer, where we capture the anterior segment image and we will plan. That software helps us to transfer the data directly to CRS master. This is a planning station. We have to do our subjective planning. The main things we have to enter is pachymetry, which is usually the preferred values in the literature is 450, but we do consider doing from 400 to 450 as well. So this is a pachy apex, and the manifest refraction. Usually keratoconus patients in advanced or moderate cases, they'll be associated with very high irregular astigmatism, but we cannot correct all. So we target usually to correct most of the cylinder, so that spherical can be better tolerated with spectacles in post-operative period. And optical zone we usually consider for 6 millimeter. And here we have 3 options in this platform. One is the first one is topography guided. That's what we are doing. That's called Athens protocol. And the topography smooth. Topography smooth is a software which just regularizes your cornea. It's flattening the speed brakes on the road, so that they'll have better curvature on the anterior surface, and there is standard spilocylindrical correction. So this gives a 3D image of the patient's cornea actually, that I'll show later. If you see this case, he has a central slightly superior cornea with keratometry of about 52. It's not okay. Yeah. So what we do, this is basically like dependent on our subjective refraction. A very good refraction has to be done to confirm the axis. Otherwise, it will ablate in a different axis, and that will be more trouble. So what we have to do, we have to ablate this region of the cornea, and this will be our exact ablation pattern, and it can be represented by 3D also, like what we are doing. This is the pre-op photo. With this ablation, we had experience about 30 years with follow-up of almost 2 years. At 1 year, mean uncorrected visual acuity improved from 0.5 to 0.4, and BCVA improved from 0.42 to 0.23, and 28 eyes gained 2 or more lines of uncorrected visual acuity post-procedure by 6 months. The mean keratometry were reduced by almost like 1.7 diopters and 2.18 respectively, and Kmax up to like 4 to 5 diopters have been flattened. This is one such case. He had almost like a central cone with moderate. This is a case which I had shown as a workup. He had thickness of only 429 with maximum keratometry of 58, and he had cylinder of about -6. We will be correcting here only -3, because if you see here, he had a thickness of 429, so we can ablate up to only 54 microns in this case. So we have residual of at least 375. So this is a pre-op ablation pattern. When we are planning only, it shows like how do we, this is the cone, and this is our ablation pattern, which if you see it's like completely there will be flattening of the cone. This is post procedure at the end of 1 year. The cone is totally flattened. You can actually see the comparative video here. So this is the follow-up result of this patient, almost like a 1.5 year follow-up. He had a K1 of 52, which was reduced to 51.4, and K2 of 55.7, the drastic reduction of about 3.4 diopters, and astigmatism is also corrected up to 2.2 diopters. So definitely with the advent of technologies and more better platforms, management of keratoconus is taking a next seat. I think this is one of the like best option which we can do to give an uncorrected best visual acuity even for keratoconic patients. And few of our patients even have 6 6s uncorrected at 6 months follow-up as well.
Which riboflavin you use normally?
See, it depends on like whether my criteria is without epithelium. If thickness is more than 400 or less than 400, we go for hypotonic. If it is less than 400, if it's more than 400, we'll go for isotonic.
And how will you remove the epithelium, your preferred way?
No, only with alcohol.
With alcohol?
Yeah.
Because alcohol with Topoguided CXL.
Yeah. And one more thing, I even do use mitomycin C. My preferred protocol is like I do it for 10 seconds for every diopter. Yeah, they will have certain pain, that's okay, but at the end of the 6 months they'll be very much happy.
Usually what we use is isotonic one, and the 0.25 or 0.22% riboflavin normally. That is what
that's
is
the
advised.
normal thing. Yeah. See, there are two things here, whether you have to use Dextron or HPMC. But Dextron, if you use, there will be like hygroscopic it is, so thickness will further reduce. So it is always better to use HPMC preparation.
And how long you irradiate?
Yeah, irradiate. It's usually accelerated protocol, and our one more protocol is coming up. It's for adapted fluence for the thickness of less than 350. We have our own calculator. It's in the review for the publication, so we are recommending it soon in the cornea.
Any other questions from the audience?
This case, like for example, the limiting factor was that you can ablate only 50 microns. So I would probably prefer reducing the optical zone to 5 and being able to remove more cylinder.
Because
as it was a central cone, you can always do that.
And one more thing, that's what our usual, this is one of such case. In the beginning, I just wanted to show that because we don't know the results, long-term results. There is only one paper published by Canalipolis, and I think they had done only some 10 cases. That was a retrospective case. And this series, we are still trying it, and longest follow-up is almost like 3 years now, and all are stable. None of them are progressed with spectacle corrected vision, not contact lenses. Yeah, that's around 64 cases.
So, but this works good for the central cones, I guess.
And one more thing is like there he has corrected maximum of 50 microns, and he has done resident protocol there. And here, that is one more thing. He has not touched any eyes which is less than 400 microns.
So just to sum up, you are using the alcohol to remove the epithelium. Then you are using the hypertonic riboflavin, PRK.
Depending on the thickness.
Yeah, depending on the
Yeah.
thickness, of course.
Yeah.
Or without Dextran, the
Yeah,
PRK
yeah,
and all.
yeah.
That is the one you use.
Yeah, yeah.
And you irradiate accelerated one or the conventional
Accelerated
one?
one.
Accelerated one. What are
Accelerated.
the energy settings? Can you some?
9 milliwatts for 10 minutes.
Okay, that's the way. All right. And what about the inferior cone? Suppose you have inferior cone, then
Yeah.
does it work well?
Yeah, usually we try to ablate or whatever we do in the central 7 millimeter. It usually doesn't work much for inferior cones. At least it should have been in central 5 millimeter is most ideal, what I'd say, instead of 3 millimeter. See,
Good
yeah,
result.
it just regularizes like speed breaker on the roads, no? It smoothens. Otherwise, if there are inferior cones, you can go for the other normogram, that is Topo Smooth. It just regularizes your entire cornea from whatever, if you take 7 or 8 millimeter, it just regularizes up to 20 to 30 microns.
Because nowadays, there is a lot of talk going for the track, but that is only exclusive to the Swin platform, where even if you have a decentered core, inferior cone, you can only ablate a particular area. Ablation is limited to that. You can do it topo-guided.
Yeah, even
But it is not with any other machine
yeah.
apart from the Swin.
No, actually, we are with in talk with the Zeiss. Even this platform provides that. Zeiss only has not published the data still.
I'm using Zeiss since 2012. I don't think they have it yet.
Yeah. They have it. Yeah.
Exactly.
Yeah.
Okay.
This is like combination of both topo guided as well as subjective refraction. If you really do subjective refraction with topo guided, it will definitely hit on your cone only.
Okay.
Yeah.
So I think it's a good modality that we can offer some kind of refractive correction to our keratoconus patients.
Yeah.
Exactly. VCVA improves.
VCA, it always improves, and most of the people definitely won't be like willing to spend so much for rose scale lenses. It's very costly. So we can better accept it with the normal soft lenses only.